You are listening to part 73 of our series, 7 Medicines, The Wise Woman Way, with Susan Weed at Time Monk Radio. Hello, Susan. Welcome back to Time Monk Radio.
Thank you so much, Gemini. It's always such a delight to be here and to be with you and to have this very, very special opportunity to really go deep and to get rich and abundant with people. You know, so often I'm teaching someplace and it's like, okay, tell us everything you know in an hour and a half. So to have the luxury of going on for more than a year about one of my favorite topics, the 7 medicines, the 7 rivers, the 6 steps of healing, is such a tremendous delight. And we have been really diving deep into the river of drugs. We have been looking at pharmaceutical medicine for many, many months now. And I keep saying it is an astonishment to me in many ways because I have been healthy and because I've used herbs to help me maintain my health and to deal with any aberrations from health. I have been very much apart from what's going on with, I'm going to call it the drug culture in the United States. I know that back in the 60s when we said the drug culture, we meant something different, but I mean the drugs that everybody is taking here. And my astonishment at how many people are taking how many drugs. And that's especially true with what we're going to be looking at in this series. And we're going to be looking at what used to be called acid indigestion, what used to be called heartburn, but now has got a much fancier name, and that's gastroesophageal reflux disease, GERD for short. So let's take a moment and review for ourselves a little bit of the equipment here that we're talking about and what's supposed to be going on. You are sitting down to a delicious meal, and you're chewing and swallowing that meal. And as you swallow, that food is going through your esophagus. And the esophagus is the tube that connects your mouth to your upper gastrointestinal system. That's the part above the intestines or the stomach, but that also includes the stomach and then the organs just after the stomach, the liver and the gallbladder and the pancreas. And someone once characterized the digestive system to me as one tube that starts at your mouth and ends you know where, with various sizes and abilities and outpouchings. An interesting way to think of it. So here's our food going down the esophagus, and it's going down the esophagus to the stomach. Where the esophagus meets the stomach is not very well defined. There is a ring of muscle there, and that's called a sphincter, just like the anal sphincter. As a matter of fact, there's 2 anal sphincters. There's a sphincter or a ring of muscle there that is supposed to open up when food is moving down the esophagus and going into the stomach, and then close up when we're no longer eating. So you're chewing and swallowing, and the esophageal sphincter is opening and letting food into the stomach. And then, yes, indeed, you take that last little sip of whatever it is, infusion wine, water, and pat your lips, and you're done eating. And that sphincter then is supposed to close tight. And in the stomach is basically divided into 3 sections, and there's kind of the waiting area, the receiving room of the stomach, which is where the food is right now. And then as the food goes deeper into the stomach, it starts being acted on by protein-digesting enzymes and hydrochloric acid. Now, if you think about it, protein-digesting enzymes, we're all hunks of protein. And hydrochloric acid, these are nasty things. And fortunately, the stomach is protected by a thick lining of mucus-producing cells that protect it against these protein-digesting enzymes and the hydrochloric acid. And the stomach curves around a little bit so that as the food gets down to where this is happening, it is supposed to be away from where the esophageal sphincter is. The last part of the stomach is when the food has been acted on, and now it's gotten kind of, it's kind of like the stuff that you throw up. It's kind of liquidy, or if you have diarrhea, it's liquidy with some hunks in it, and that's what's going to move out of the stomach and into the duodenum, or the very beginning part of the small intestine. Now, what can happen is that sphincter at the esophagus, where it connects to the stomach, can get relaxed. Age will relax it. Yeah, pick parents or grandparents who have that particular muscle in a fairly relaxed state. Genetically, you're going to have it more relaxed. Posturally, hanging out, leaning back, laying down. The Romans did not have a good idea with laying down while they were eating. Better to be upright. That keeps the food in its proper relationship in the stomach. Obesity, because the fat actually pushes the stomach higher up into the body. Any pregnant woman can tell you that her stomach is trying its best to move right up into the upper part of her chest. And, of course, acid reflux is fairly common toward the last part of pregnancy when there is that push. So there's a variety of different things that can, shall we say, mechanically cause that sphincter not to work well. And then there is also the understanding that herbalists and healers have had for many thousands of years, and that is that things need to move along in the digestive system. So when we swallow something and it goes to the stomach, it needs to be acted on by that hydrochloric acid and acted on by those protein-digesting enzymes and turned into chyme and discharged into the duodenum. It wants to move along 4 or 5 hours in the stomach and then move along. In some people, that motility, that movement slows down, and the food stays in the stomach for too long, and then it begins to push back up into that waiting room, into that antechamber that we were talking about, and the actual force of that food pushing up can push back up into the esophagus. So there's a horrible feeling when that happens. There's an acid taste in your mouth, a sensation in your throat of acidity, burning, pain, discomfort in your chest, in your throat, upper abdominal pain and fullness, belching, regurgitation, even nausea, vomiting, bloating, flatulence. You just get full really fast and you just lose your real appetite. Now, it used to be that when someone had these symptoms, we said, you have acid reflux. Take some calcium carbonate. And there were some people who didn't get better with that. And when we looked at those people more closely, we saw that they had a hiatal hernia. That, in fact, where the esophagus goes through the diaphragm, in other words, it has to pass down behind the heart, lungs, and through the diaphragm, which helps us to breathe, to get to the stomach. That opening in the diaphragm, just like the sphincter in the esophagus, had gotten a little relaxed. And now, again, the same kinds of mechanical and genetic things can cause the stomach not just to have contents that push up into the esophagus, but the whole stomach itself pushes up, tries to push up into the diaphragm. Needless to say, that causes a lot of pain. Certainly surgery can be done to close that down, but it's a tricky surgery to repair a hiatal hernia. And thus was born the proton pump inhibitors, the drugs that actually inhibit the stomach from making acid. These are an absolute lifesaver and godsend to people with hiatal hernias, because the ordinary things, the things we're going to talk about, to relieve acid indigestion, to relieve GERD, they don't work for somebody with a hiatal hernia. Surgery or proton pump inhibitors tends to be the very best treatment for anyone who actually has a hiatal hernia. Other than that, diabetes, smoking large fatty meals, bulimia, the other things, those are more in our control. And there's this belief among herbalists and healers that what needs to be happening in the stomach is for the stomach acid to be high, and that breaks down the food and gets it out of the stomach before these other things can start happening. You'll find that in most instances, the recommendations for people who have acid reflux or for people who have GERD are to avoid things that increase acid in the stomach. And when I was looking at herbalists and what herbalists say, even very well-respected herbalists say, don't use bitters because bitters increase hydrochloric acid in the stomach. And with GERD, we don't want any more acid. Well, here's a very interesting study that I found when I was looking to see what was out and about. Of course, what we're all basically assuming is that the stomach acid is splashing up into the esophagus and is causing problems in the esophagus as a direct result of that acid and those protein digesting enzymes. But this study, which looked much more carefully at what was going on with people with GERD, actually found that it was inflammation that was causing the damage. In many cases, it was that backwash of acid that was triggering the inflammation. But they found people that had that kind of acid actually touching the esophagus, which is not as well protected from it as the stomach is. But if there was no underlying inflammation, then although there was certainly feelings of discomfort when that acid touches your esophagus, you feel it and it doesn't feel good at all. Remember, that's right behind there, right where your diaphragm is. And it really does feel like a heart attack. Sometimes it can be so, really wow. Right, so as we look at what's going on here, keep in mind that there's this difference of opinion, that most people are going to say acid reflux and gastrointestinal reflux disease means you want to calm down the acid in the stomach. And there's a dissenting view that says this is happening because there's not enough acid in the stomach. And we want to encourage that so that the food moves through the stomach more quickly, as with all things, but especially with our digestive system. This is a very idiosyncratic and very, very personal kind of thing, and the symptoms can be quite different from person to person. As a matter of fact, some people don't even have that burning sensation unless they bend over or lie down. And some people don't get it at all. They get more of a choking sensation. And there are people who have a chronic cough, hoarseness, frequent throat clearing, or even difficulty in swallowing. When my dad died, I began to cough. And we're not talking, we're talking, I would wake up in the morning and I would cough to the point where I would almost throw up or I would almost pass out. I would cough for 2, 3, 4 minutes, long, laborious coughing. I had a pretty strong feeling that it had to do with grieving for my dad and my dad's desire to, help me get along in the world by washing my mouth out with soap and basically preventing me from saying what I wanted to say, and that I was just coughing all of that up. But I also knew that my mom smoked cigarettes while she was pregnant with me, and basically the entire time I lived at home before I went off to college, and that secondhand smoke, the risk of lung cancer is greater in people who have the secondhand smoke than the people who are actually smoking, and that a cough like that could be an indication of lung cancer. So I gave myself a time limit. And when I was still coughing, to that extent, my time limit was up, I did indeed seek some high-tech diagnosis. I wanted an X-ray. I wanted to look at my lungs and reassure myself there was no cancer noodling around down there. I was quite astonished when, after telling my tale, about my mom smoking secondhand smoke and so on. The doctor said to me, "You probably have GERD." It had never occurred to me before that moment that coughing could be a symptom of GERD. In 2002, 15 years ago, it was estimated that about 20% of the American population had gastroesophageal reflux disease. About 10 years later, it was estimated that about 40% of Americans had GERD. And in the research that I've been doing over the past few weeks, I have come up with a few estimates as high as 60% of Americans will have one or more episodes of GERD during their lifetime, especially as they age. GERD is strongly associated with older people, with the incidence being highest among women and very highest among older women. Fear factor here, I think, is esophageal cancer. I kept seeing mention of it over and over and over again, that if you have GERD, you have to control that GERD because you can get Barrett's esophagus, and that Barrett's esophagus can lead to esophageal cancer. So, being the kind of scientist that I am, I wanted to find out what's the likelihood of that. About 1 in 10 people who have GERD, about 10% of them, have a condition which actually changes the esophageal cells into cells that look more like the cells lining the intestine. And I find that wonderful and amazing because the cells lining the intestine are protected against acid. And saliva is very alkaline and it neutralizes acid. So we also find that people who are well hydrated and who have adequate saliva have far less problem with GERD than others because of the alkalinity of their saliva. So the cells start to resemble those lining the intestine. What a magnificent way our body has of protecting us. However, that means those cells are undergoing changes, and those changes can lead to cancer. So we have about 10% of those with GERD who have this change in their cells, and of those, 1 out of 100 of those people, or about 0.01% of all of those with GERD, will actually wind up with esophageal cancer. This is a very small number of people. And when you consider that more than 15 million Americans were prescribed drugs to control GERD in 2013, and certainly far, far more than that right now, as well as the people who buy drugs to control GERD over the counter, we can see, as one doctor puts it, that we are in the midst of an epidemic of the overuse of medications for something that used to be considered just an ordinary part of life and aging, and that is now considered a threatening condition that could lead to cancer. I also want to mention that there's an autoimmune disease called scleroderma, which causes hardening of connective tissue. And it can affect the esophagus. And as many as 90% of women who have scleroderma have heartburn as well. And especially in women doing ab crunches, weightlifting, and other isometric exercises can actually weaken that sphincter that we're talking about. So watch it, ladies. All right, let's talk a little bit about those drugs that are being prescribed and look at some of the ways that modern medicine is dealing with a disease that is partly being created by the availability of the drugs, and we almost always see that when there's a drug that treats something, suddenly there's a lot more of that something that is also being driven by the huge increase, almost a doubling of people with obesity and diabetes, both of which can really trigger GERD. So initially, the kinds of drugs that people used were antacids. And liquid antacids work better and faster than pills, although there are those who say that the pills are more protective of the esophagus because they stay in the esophagus for a longer amount of time. Calcium carbonate is the classic substance to relieve acid indigestion. And, of course, it's also promoted for adding calcium to your bones. Aluminum compounds are available. They don't work as fast as calcium carbonate, and they cause constipation. And if you keep taking them, they actually deplete your calcium. Magnesium carbonate is also used, and it can have a laxative effect, which some people like. Overuse, however, can mess with your heart rhythm, especially in older people. There is an anti-foaming agent called simethicone, and a simethicone is used for people with acid indigestion, but there's not very much evidence that it's very effective, and especially not for GERD. Alginate is very similar, except instead of being an anti-foaming agent, it's a foaming agent. And alginate, or alginic acid, is derived from seaweed, and it's basically sold in Canada and Europe, and not very much in the United States. But it is fairly effective at relieving mild to moderate GERD symptoms. And if you're thinking, oh, maybe I could just eat some seaweed, well, stay tuned. We're going to be talking about that. Sodium bicarbonate, baking soda, is the active ingredient in fizzy antacids like Alka-Seltzer. But there's also aspirin in Alka-Seltzer, and that turns out to be a problem because remember that aspirin can cause gastrointestinal bleeding, and it's salicylic acid. So we don't really want to be putting a drug acid in there. Also, these kinds of things are usually very high in sodium, so not recommended. Pepto-Bismol is bismuth subsalicylate, and that's not really recommended either because salicylate is aspirin, and it can be quite irritating. So these are the things that used to be used, and generally they were fairly effective, except, of course, for the people with hiatal hernias. And then we got the H2 blockers. These are histamine antagonists, and they reduce the production of stomach acid, which is stimulated by histamine instead of neutralizing it. All the things we just talked about neutralize stomach acid, but the H2 blockers actually reduce. They were originally only available by prescription, but now you can walk into a drugstore and buy Zantac, Pepcid, Axid, or Tagamet. It takes about 30 to 60 minutes for them to start working, so people usually have to take them before they have any symptoms, which is quite different than the antacids that we're talking about, which are taken after you have symptoms. What happens when we take a drug prior to having symptoms is that there's no way for us to really tell if the drug is working or not, unless we do get the symptoms even though we take it. But if we don't get symptoms, we don't know if we would have had the symptoms. And we then tend to misuse and overuse the drugs. In fact, it says on the package insert and on the box and in all the medical literature that I found that you are not supposed to take Zantac, Pepcid, Axid, or Tagamet for more than 14 days. I know people who simply take one of these pills before they eat to prevent any problem. This is not the way these drugs were meant to be used. And there's further problems in that they interact with quite a few other drugs. Next level, PPIs, proton pump inhibitors. They turn off acid production in the stomach. Like the H2 blockers, it takes 30 to 60 minutes for them to work, and so people take them before they have any symptoms. Very good studies have found that for the vast majority of people, if you simply take them for the prescribed amount of time, which is about 14 days, and then gradually taper off over the next week to 10 days, most people will be symptom-free for months. You might need to cycle through taking a PPI for 14 to 21 days several times a year. But again, these drugs are not designed to be taken on a daily basis. Proton pump inhibitors are now the second largest selling drug in the world. Prilosec, Prevacid, and Nexium. There's basically no difference between them. But like the H2 blockers, they should not be taken for more than 14 days and not any more often than 3 times a year. In other words, not more often than every 4 months. These directions are right there on the package and on the insert. 14 days is sufficient to resolve chronic heartburn in the vast majority of people, with the therapeutic effect persisting for months afterward, but we find this is not how they're used. Depending on how severe your GERD was when you started taking the drugs, it's best to gradually reduce the dose. Use the lowest dose that works for you and then taper off. Don't just stop taking H2 blockers or PPIs because the symptoms will often rebound. If the drugs don't work for you, there is a new surgery that is minimally invasive and which a little tube is put down your throat and a little lasso is put around the, it's not really quite down your throat, but it's okay. I'm not going to go too deeply into it because we're all going to go if I do. But the transoral fundoplicate, wow, is that a great word, can actually help to close the lower esophageal sphincter. About 40% of people who take proton pump inhibiting drugs still have symptoms. Now, don't think that then implies that if you go ahead and have the surgery that you won't also have to take the drugs, because, in fact, a great many people who do have the surgery do continue to have to take the drugs for full control. Proton pump inhibitors do not improve the barrier function between the esophagus and the stomach. So even though they turn off acid production in the stomach, there are still inflammation, remember, going on there, and there can still be distress and pain. The transoral fundoplication eliminated regurgitation in about 67% of people versus 45% just taking proton pump inhibitors, and provided a greater reduction in heartburn than the placebo group. It's probably not a permanent solution, but it will buy some time for the esophagus to heal. And if it can make you drug-free, certainly a better kind of surgery than a hiatal hernia, but not going to help people who actually have a hiatal hernia or who are obese or diabetic or have scleroderma. So once again, the drug and surgery options that we are being offered are very short-term kinds of things, do not lead to greater health. I'm going to be back with you next week, and we're going to talk about how serious these proton pump inhibitors are, because they are dangerous drugs. But that's all the time we have left for tonight. Thanks so much for helping me reweave the healing cloak of the ancients. And we're restoring herbal medicine as people's medicine. Good night. Thank you, Gemini.
Thank you, Susan, and we look forward to next week. And this concludes part 73 of our series, The 7 Medicines, The Wise Woman Way, with Susan Weed at Time Monk Radio.